Good afternoon, everybody. My name is Kayla Huggard, and before we get started, I would just like to take a second and acknowledge that I did the following work and am giving this presentation on the unceded territory of the Lekwungen-speaking people, Esquimalt First Nation, Songhees Nation, and Wasanich peoples. I'm an uninvited guest to these lands as I'm a white settler who was born and raised on Treaty 7 territory in Alberta. I am here today to discuss with you what personalized risk and wellness management looks like from a decolonized harm reduction approach. So this is going to be our guiding graphic for today. As you can see, the two parts of my project title are included: the personalized risk and wellness management plans on the left and decolonized harm reduction on the right. In order to understand how these two come together, we will look at a dual model of housing care and land-based healing camps. My practicum was completed with the Aboriginal Coalition to End Homelessness here on Vancouver Island. The organization is Indigenous-led, with their main goal being to lovingly support Indigenous people experiencing homelessness. It is key to note that due to social and structural determinants of health, such as housing and racism, the population the coalition serves often have complex wellness states, whether that is challenges of addiction, chronic disease, ongoing infection. In order to meaningfully help the population served, one of the coalition's main initiatives is the creation of a dual model of housing care framework. On one side of this framework, it's to provide culturally supportive housing, and on the other, it's to cultivate Indigenous pathways to healing and recovery. The reason behind needing both housing and pathways to healing is that if only housing is provided, people are simply just given a space where they will continue to deal with the same challenges they would on the streets. When we have housing and pathways to healing, that's when real recovery can manifest. So when we examine the Indigenous pathways to healing side of the model, a decolonized harm reduction approach is implemented. As many of us are familiar with harm reduction, the idea of meeting people where they are at instead of holding goals of abstinence or sobriety, harm reduction practices such as needle exchange programs and opioid agonist therapies are pragmatic solutions to addictions care. However, it's important to note that many harm reduction initiatives and narratives are Western in nature. For the coalition to create Indigenous pathways to healing, they must employ decolonized harm reduction practices. So what does this look like? A key part of decolonized harm reduction is physical health, but mental, emotional, and spiritual wellness. For many Indigenous people, connecting back to spirit, culture, and land is one of the most impactful ways to reduce harm and support healing. Let's explore an example of this. One of the decolonized harm reduction practices run by the coalition is the carry-out of land-based healing camps. These are multi-day camps across traditional territories on Vancouver Island, where Indigenous people experiencing homelessness have the opportunity to reconnect with land, culture, language, and their spirit. This is done through numerous cultural activities over the course of camp, like nature walks, potlatches, language circles, and sweats. We know because of the multitude of unfavorable determinants of health the target population faces, that potential camp participants may have a large range of wellness states and challenges. To address this, a registered nurse attends these camps to ensure safety and optimal experience for all participants. This means the camp nurse has to adequately plan and accommodate for each individual participant's wellness needs. This is a tasking responsibility, and it was apparent a resource bank needed to be developed to assist the camp nurse in this planning process. This is where I come in. It was my practicum deliverable to create a resource bank for the camp nurse, and the resource bank had a central document, the second part of my project title, the personalized risk and wellness management plans. The methodology and purpose of my practicum project was to amalgamate information from both internal and external resources, along with insights from professionals, especially what was shared from elders and knowledge keepers, into useful templates that would help assist the camp nurse in accommodating for participants' needs. The personalized risk and wellness management plans were a central template that each camp participant and the camp nurse would complete together. For a point of clarification, my practicum deliverable was a resource bank, creating all the necessary templates the camp nurse may need and compiling them together. Examples of these additional templates include a proposed timeline, an alternative communication plan, a medical emergency resource sheet. Although I developed 23 resources and templates making up the resource bank, today we will pull out and examine one central template from the resource bank, the Personalized Risk and Wellness Management Plans. Let us further explore what these plans looked like. So after researching internal and external resources, utilizing professional suggestions, and highlighting what community members themselves had shared, there was an understanding of what the plans needed to encompass. So I organized the plans into 3 stages. First, I created the information gathering stage of the template, which asked participants a thorough set of questions like where they go to access care, what medications they currently take, what people say their strengths as a person are, what the individual believes they are good at. I then produced the plan development stage, where the nurse and participant take the information gathered and turn it into management plans. For example, a participant may enjoy writing and has trouble falling asleep at night. So a plan can be made to set aside time each night to journal and wind down before bed. Lastly, I developed the analysis and recommendation stage, which goes beyond just the plans made between the nurse and a participant, but what accommodations may be needed when it comes to overall camp planning. For example, if a participant is a heavy smoker, smoke breaks may need to be incorporated into travel plans. Now that we know where the need for these plans stemmed from and their purpose, let's recall these plans were to be viewed through a decolonized harm reduction approach. So let's examine how the plans themselves were decolonized. Notions that were shared with me from elders, knowledge keepers, and coalition staff were used in plan revision with the hope of further decolonizing the documents. Let's explore 4 notions shared with me that I utilized in the plans. Firstly, I fostered reciprocal relationship building. The nurse is asked to get to know participants as individuals before diving into information gathering and plan development. To do this, the nurse is encouraged to share aspects of themselves, their strengths and challenges, their view and anticipation of camp. It's when both parties exercise this vulnerability that reciprocal sharing and relationships form and grow. Secondly, I embedded both strength-based and client-centered care throughout plan development. It's always how the participant wants to manage the challenge, how we can draw from their individual strengths to help overcome the challenge. Participants have control over decisions from who they want to bunk with, all the way to how they would like a conversation regarding a potential instance of withdrawal to go. Both strength-based and client-centered care approaches help make camp planning a safe and empowering process for the participants. Feeding off of strength-based and client-centered care, I worked to maximize the range of choice the participant had for how they would like to accommodate for their needs. The availability of elders at camp, what traditional medicines they may have access to, and the types of cultural ceremonies and practices one could partake in expands treatment options beyond just medications and biomedical interventions, giving participants a range of choice. Lastly, I examined and revised the language used throughout the plans. The use of open-ended questions, allowing participants to guide the conversation, share what they wish, was respected. The term health is rarely used throughout the documents, but instead wellness was used with the hope of encompassing a more holistic view of well-being. There was a conscious effort to balance talk surrounding challenges and obstacles with benefits and strengths. I wanted the language used to be as inclusive and non-triggering as possible, helping to further decolonize the plans. So when we take a step back and remember these personalized risk and wellness management plans were to be used at land-based healing camps, a program which carries out decolonized harm reduction, working towards one side of the dual model of housing care framework, we can see how all these pieces fit together. Decolonizing harm reduction was not only embedded within the plans, but it allowed larger and distinct practice of camp facilitation to safely occur. This is an example of Marshall's concept of two-eyed seeing, where the view from one eye is strengthened by the view from the other. By accommodating for these Western biomedical concerns, or the view from one eye, we are able to strengthen the decolonized harm reduction practice of camp participation, the view from the other eye. To conclude, it's through approaches like decolonized harm reduction and two-eyed seeing that meaningful steps forward on the issues faced by Indigenous people can effectually be addressed. The field of public health has an opportunity to utilize approaches like the ones discussed today to move true reconciliation forward. To conclude the presentation, I would like to take a second to thank everyone at the Aboriginal Coalition to End Homelessness who provided me with such an incredible learning experience, especially my practicum supervisor, Fran Hutchinucci and Sally Hunter-Brady, to Victoria Barr and Betty Taylor for being pillars of support throughout this journey, to other professors and peers that made my MPH experience all it was, and lastly, and most importantly, to my friends and family for their endless support and love. Thank you so much, and I would be happy to answer any questions you may have.
Wonderful. Thank you so much, Kayla. What a terrific presentation. Yeah, just so much there to, and I know that you just, again, had such an incredible experience at the Aboriginal Coalition to End Homelessness. So yes, thank you so much for your reflections and for sharing your wonderful work with us today. I would open it up to questions and comments. Oh, looks like Jessica. Go ahead, Jessica.
Hi, Kayla. That presentation was so interesting. I just had a question about the land-based healing camps. I was wondering, for the nurse that is a part of it, is this an Indigenous nurse? And I'm just wondering, I don't know if you know the answer, but like, is there a reason why it's a nurse versus like another member of the Indigenous community?
That's a great question, Jessica. Thank you so much for asking that. It is always with hope that the nurse would be someone who either has lived experience or maybe past experience, whether that is identifying as Indigenous or having ties to the street community. This isn't always possible. So one of the documents that was actually developed was a pretty thorough introduction to the purpose and approach, and just mentions concepts such as the importance of self-locating and to ask yourself some hard questions and to get educated on matters and the population you're going to be working with prior to actually going forward with the camp, just as a barrier to be more safe and inclusive. The reason why it was a camp nurse, as opposed to maybe just like an Indigenous support worker or something like that, was due to the immense medical needs. So there's participants who have some conditions that require more consistent monitoring. If we wanted to employ a managed alcohol program at camp, that required a nurse to make sure that that was done so safely. So the fact that it's a registered nurse was just more due out of necessity, as opposed to maybe what the best fit in a supportive role would be. Does that answer your question?
Yeah, that's awesome. Thank you.
Okay, any further questions or comments for Kayla? Oh, Annika. Go for it, Annika.
Yeah, Kayla, I'm so impressed by the amount of work that you did. And so I was wondering, of the items in the resource bank that you didn't get to talk about, what's one that you would like us to know about on top of the wellness plans?
Ooh, that is a really great question. There was lots of documents that were a big learning curve for me, so I wish that I had enough time to share it all with you. One specific document that definitely stands out was relating back to if a participant wished to have a managed alcohol program while at camp. The goal of doing so would be to keep participants in an ideal state. So we don't want participants to have to go through experiences of withdrawal, but we also don't want them to have to go through experiences of intoxication. So it's trying to figure out that happy medium to make sure that participants stay safe and they can have an optimal experience at camp. When trying to develop that plan with participants, sometimes it was hard to communicate that that was what we were trying to do. So I developed a visual that just showed kind of the continuum of like, we don't want to be on this side and we don't want to be at this side. We want to help you get to your ideal state. And we want to know what that ideal state looks like for you. So that was definitely something that I saw in practice with participants, really kind of having that click moment of like, okay, yes. I also found that the nurse really appreciated having that additional graphic as opposed to just trying to communicate verbally. So I would say that that was probably one of my second favorite resources.